undergoing curative anticoagulation. I know her because she was addressed at the beginning for a cirrhosis, which was related to chronic alcohol consumption and also to metabolic syndrome, what is quite frequent in France. And at the beginning, the story started with ascites, but finally we succeeded to control this ascites thanks to diuretics. And this woman never presented any hepatic encephalopathy or variceal bleeding. When I met her, she was presented a compensated cirrhosis with a Child-Pugh A score and a MELD score of 9. Regarding her medication, she was still under diuretics, but also she was treated for arterial hypertension and also her diabetes, and she was with warfarin for her atrial fibrillation. So when I met her, so at the beginning, she also presented an HCC. So this was quite a long time ago. It was in 2015, and she underwent the surgery for one lesion of HCC of 25 millimeters. And when we look at the pathology, we saw that finally it was quite a good prognosis without any vascular invasion or any satellite nodules. So then we continue the surveillance, and unfortunately in March 2021, she presented a recurrence of her HCC with, as you can see here, a massive tumoral recurrence about like 6 centimeters. It was quite infiltrative, and also we noticed a portal invasion. And so at that time, we classified our HCC, well, because here we usually use the BCLC classification. And so we classify this lesion BCLC-C because she didn't present any extrahepatic spread. Regarding the biology, she was still with a compensated cirrhosis. She was classified Child-Pugh F5, MELD score was 9, and she had an ALBI score of 1. When we calculated the alpha-fetoprotein score, which is what we are using in France to access to liver transplantation, this was really high. It was at 4, and usually we can propose liver transplantation to patients with an alpha-fetoprotein score lower than 2. And as you can see, our alpha-fetoprotein at that time was really high because it was more than 12,000 nanogram per milliliter. So my first question for you is, in this situation, which treatment will you propose first to these patients? So I don't know if we can discuss a bit. I don't know for if you would propose maybe a local regional therapy, or if you go through systemic therapy directly. I don't know, what are you using to do in your respective countries?
Do you have any comment from audience?
This patient, in my place, we would, since the patient has extremely good liver function, though the platelets are low and the portal vein is invaded, patient could be considered for SBRT, and with a portal vein which can be directly focused by SBRT. So my first choice would be, and the AFP is very high, so I would think SBRT could be considered. If the patient has liver volume which is less than 700 cc, then maybe systemic therapy. But if the remaining future liver volume is good, a patient can be considered for SBRT.
I think this is from Australia. I agree that's current practice as well. So someone like this is 65 years old, otherwise well, with good liver function, and a lesion that is 6 centimeters, single lesion with portal invasion, we would be leaning towards radiation SBRT. And second option being systemic therapy.
So maybe in Japan, we will use the heavy particle beam therapies, a kind of radiation therapy. But we think the size of the tumor is 6 centimeter in diameter, so maybe SBR heavy particle beam therapy would be better for this size of the tumor.
So thank you for your answer. Well, in France, we are not really used to use external radiotherapy. When we have vascular invasion, usually we move quite quickly to systemic treatment, especially in this patient with an high alpha-fetoprotein level. So this is mostly the strategy we are using in France. And so for this patient, indeed, it's what we choose. And our question next was finally which kind of systemic therapy we could propose to this patient. And currently in France, we can use so atezo-bev as well, almost everybody, but also we have access to durvalumab, and for sure the usual tyrosine kinase inhibitor. So this was a bit our question. And so in our tumor board, so yeah, our next question was which treatment should we use between these three strategy, considering for sure that this patient, she has a preserved liver function, but she has an history of ascites. She has a low platelet levels, as you already noticed. And one point also important for us was that she presented vascular invasion and also active anticoagulation. So my next question for you will be, in this situation, if you want to choose between these three strategies, will you propose any additional tests in order to assist you in choosing the treatment you will use?
May I give a few comments on this interesting case? Yes. I'm Joshua from Hong Kong. I'm also practicing in Shanghai, in China. If we encounter such a case, I don't think we will give SVRT as a consideration, but rather systemic therapy. And taking into considerations of doing systemic therapy, because the patient has portal vein invasions, vascular invasions, and also with ascites, one will be worried about the presence of varices in these patients, and endoscopy is a must. Because if one would like to use atezo-bev, there is a risk of GI bleeding in those cases. So I think if we can do good endoscopy and bending, if there's any varices, then we can consider either atezo-bev or the strike therapy, as indicated here, with the use of high-dose tremi and the durva. But if endoscopy is not going to be performed, then I think the strike therapy would be the options as a first-line therapy for this type of patients with liver cancer recurrence 6 centimeters, and also with a very highly elevated alpha-fetoprotein.
Thank you for your comment. So exactly, well, our next step for this case was to assess portal hypertension, because as you just discussed, we know that there is maybe an higher risk of varicose bleeding under bevacizumab, and this was already shown in some studies, as this one published in 2012. And in this series, considering some trial about bevacizumab use for HCC, they show indeed quite an high incidence of gastrointestinal bleeding. So this could be something that could prevent us to prescribe atezo-bev in the setting of something which could bleed, such as varicose bleeding. So this was also what we were wondering, if this patient present clinically significant portal hypertension or not. And so at the beginning, we started to do like simple measurement of portal hypertension features, such as the liver stiffness measurements, which was 13 for this patient. And we also already knew her platelet count level, which was lower than 100,000. So my next question is for you. In the setting of HCC, do you use the usual BAVNO criteria that we are using in patients with cirrhosis to diagnose patients with clinically significant portal hypertension or no in your current practice? Will you just use platelet levels and stiffness measurements, or will you go further doing endoscopy, for example?
Oh, endoscopy should be done.
Yeah.
It's a very good question.
Endoscopy should be done at the very beginning. I mean, it's a common practice in the gastroenterology department. Why not?
I agree with you. It's what we are doing, but it's a question because, well, maybe more in Europe or in France, we are always discussing, should we do this endoscopy or not? Because if we know that patients with clinically significant portal hypertension maybe should directly go with beta blockers, for example, and with some for who we know that they won't present portal hypertension, maybe endoscopy is not mandatory, and so we do surveillance of this patient doing a liver stiffness measurement every year to see how things are evolving. But this is a question we have in France, at least, is maybe to avoid some endoscopy to some patient. But in the setting of HCC, I do think that we need to use endoscopy, and I will show you after some of our results. And this is just to remind you a bit the BAVNO criteria, because this field has evolved within the last year. So before, we were used to use the BAVNO 6 criteria, which had the aim of this was to finally prevent acute variceal bleeding. And this BAVNO 6 criteria allowed to identify patients with low risk of large cell varices. These were the patients with platelet counts, platelet levels, higher than 150, with a liver stiffness measurement lower than 20. And for this patient, so this was study performed on patients with cirrhosis, no HCC patient. This is important to notice. And for this specific population of patients, we admitted that the risk of large cell varices was really low. And so we did not perform endoscopy and we did not propose any prophylaxis. So this was before. Now the concept of BAVNO has evolved, and now it's not a question of preventing acute variceal bleeding. It's more to identify patients with clinically significant portal hypertension, who will be at higher risk of presenting liver decompensation. And with this new criteria now, you can distinguish two groups. One group, which is estimated with a low risk of clinically significant portal hypertension, the one with platelet counts higher than 150 and a liver stiffness measurement lower than 15. And for these patients, so this is the same, no endoscopy, no prophylaxis. But what is interesting in that in this new recommendation, they propose also a group, so patients with cirrhosis once again, in whom for sure you will have clinically significant portal hypertension, so the one with a liver stiffness measurement higher than 25. And so in this patient, you don't need to perform endoscopy anymore, but you just put your patient under beta blockers. So this is a bit the new concept. But what is important to notice is that in these studies, which allowed this recommendation, HCC patients were not included. And so in this condition, we perform, so in Lapiti, in my hospital, these retrospective studies in which we included 200 HCC patients with all different stages of HCC, so early, intermediate, and also advanced stages. And we also identify the performance of BAVNO6 and BAVNO7 criteria in our population. And when we considered all the cohorts, so if you have a look to the BAVNO6 criteria, so usually when you considered with your patient with favorable BAVNO6 criteria, you want to have less than 5% of patients with large size varices in this group. And so when we perform our analysis in our cohort, you can see that finally, in our patient with favorable BAVNO6 criteria, 8% of them presented large-sized varices. So this means that these criteria were not really performant in our HCC patient. And this was also confirmed when we considered only patients with early-stage HCC and also patients with advanced stage HCC. And for the patient with advanced stage HCC, what is important to notice is that the results were even worse when we had patients with vascular invasion and infiltrative forms. And we also did the same kind of thing with the BAVNO7 criteria. So this time considering patients with for who we had the venous pressure gradient. And here again, you can see that finally, when we considered favorable BAVNO7 criteria, which are summarized there, we had 23% of our patients who had clinically significant portal hypertension based on the gradients. So finally, for us, we do think that BAVNO criteria are not applicable in HCC patients, and we should perform a endoscopy to diagnose portal hypertension in this patient, as you just suggested. So if we go back to our patient, finally, we did perform this endoscopy, and what we observed is large size varices with red mark. So just to remind you also that finally we are in the setting of primary prophylaxis because our patient never bled. But in this setting, in this primary prophylaxis, according to your practice, what will you propose? Do you propose just beta blockers, or do you also propose ligation, or do you do both in such situation?
Yeah. Bonding.
Bonding for you?
Yes, bending. Adequate bending. I suppose there is no gastric varices in this patient.
No, exactly, no.
Okay, it's just esophageal. With the red marks, it's must to bend. But having said that, even with bending, I would still go away from atezo-beaver, but to use strike therapy in such cases.
Okay.
Well, the George tried to sell the stride, but in reality, not many people using the stride yet. You got to be careful about that.
I'm just because of this aggressive endoscopy picture, one will be very worried, and I'm pretty sure he has a high-grade portal gastropathy in these patients. If that is
it can be lenvatinib first.
Yes, yes.
I have a slightly different opinion than Dr. Lau. I would like that the patient must be started on beta blockers. An adequate beta blockade is required in this patient, number one. Number two, the patient should not be taken up for a band ligation at this time. There is a high risk of rebleeding and risk of ulcers. So I would just put the patient on beta blockers. And yes, there is a risk of giving VGF, bevacizumab, and others, but we are using it regularly. We haven't had any problem, but wherever we have done band ligation, there has been more challenges. So my choice is beta blockers, adequate, and careful watch on this. But maybe Professor Omata may have a different suggestion.
Well, we don't have much experience about the beta blockers because we are the endoscopist that doesn't do the indirect way like a pharmaceutical treatment, but basically they just go into the risky viruses as a banding very quick.
Yeah. Well, as Professor Sari, you mean you are going for beta blocker without bending? Or I'm sorry, I missed that point. You don't do even
I
do
will
bending.
do beta blockers,
Uh-huh.
and I will not be using bending in these patients
Mm-hmm.
because it may create. So once we have either we have time enough to do bending and eradication, but we don't have enough time, and we have to start therapy. I'll just give beta blockers for 3 days to escalate to the target heart rate, and then it is as good, probably. But I will like others to advise on this. This is a very controversial area.
I think we like among our colleagues in Newcastle, we have different opinion on similar cases. Like my preference is similar to what Professor Saran is saying, which is even though there are red whales and other science, in this setting, I would rather, because this is primary prophylaxis, I would rather just start the beta blockers and get on with the immunotherapy than to do the banding and then potentially risk a severe post-banding bleed, or also potentially delay the immunotherapy because you should wait at least some time, a minimum 2 weeks, sometimes even longer, for the ulcers to heal before you start the bevacizumab. So I would prefer to take the risk and not ban and just go with the beta blockers. But if I ask half my colleagues, I think there'll be 50-50 on both sides. It is a tricky one.
In fact,
patients dying. Look at the alpha fetoproteins. Is almost 12,000. And then when at the very beginning, the pathological diagnosis, Edmondson class 1, which is a little bit strange for me. How come that you can have a Edmondson 1 stage cancer suddenly develop 12,000 AFP levels? That can be high at the very beginning too. So that's not concordant. In other words, Edmondson 1 and then high AFP. So that's something is missing at the very, very beginning. And the patient dying of the hepatic failure or maybe hepatocellular carcinoma, not the portal hypertension. So it's not a big issue about this case in particular, about the portal hypertension matters.
Well, I echo with Professor Omata. In fact, maybe I missed the presentations after the resections, and the patients have recurrence, and how was this alpha fetoprotein being monitored after
alpha fetoproteins? How?
Yes, it's raised so quickly. I mean, it's. I mean, how many measurements have been made before you discover this high level alpha fetoprotein?
Sure,
It's
I get you.
Yeah.
So just to tell you, so indeed, this patient, she had their first HCC, it was in 2015. Then she was followed up every 3 months, as we usually do, for 4 years with regular control, so alpha fetoprotein and CT scan. But then we lost the patient, so during 2 years, she didn't have any control. And so we met her again at the point when she really advanced HCC. So sorry, I mean, you're right. You're right.
Right.
And this is 6 years after the original resection.
Exactly.
So this is not a recurrence of the cancer. This is a new cancer.
Like a new cancer.
Not necessarily. I don't agree with this. Not necessarily, because there is a gap. You don't know when the patients have the liver cancer. In other words, with 2 years, right? You don't. Yeah. So you don't even know whether when they start to have the cancer. I don't think that this is proven. This is not a recurrence. But having said that, even with the primary prophylaxis with such aggressive looking varices, I just doubt whether it has bled before without being noticed, and whether this is really a primary prophylaxis. And in my clinical practice, I would not doubt to do banding on these patients, because we have seen so many cases of horrific bleeding afterwards if we do not band initially. And the blockers is difficult. Yeah, that's...
No, I don't think so.
So, excuse me, is it really necessary to do the treatment of varicella S1 varices with a patient with HCC with portal vein tumor thrombosis? maybe so. We are not sure whether the patient will develop varicose bleeding or not. So maybe we should start the treatment first, because even if we do some treatment for esophageal varices, the patient have the portal hypertension and portal vein tumor thrombus, and it's developed. It will not, any treatment will not work. So we should start the treatment first for hepatocellular carcinoma for portal vein tumor invasion, I think.
Yeah, that's right. I mean, selection of the appropriate treatment, chemotherapy, is a key issue. So in that case, then secondly, how to do with this varix. So if you want to do APASL, maybe you better do the treatment for the varices. But if not, like other drugs, maybe not. So I'm saying that the portal hypertension is not the biggest issue in this matter. But for the sake of the selection of the right appropriate therapies, maybe that should be discussed.
So just to move, so what we are discussing right now and the difference we can propose according to our center and our habits is exactly what we observed in France, because with Professor Tabu, we conducted this survey, and finally we asked to our French collaborators which prophylaxis would they propose in the setting of TKI and also atezobev in patients with large site varices as this patient, considering also the presence of red marks as you discussed it just before. And what is interesting to know is that finally you can see that even while in France we have all different habits, and when we have these really large site varices with red marks, people trend to use ligation as some of you proposed today. So this is also what we observed within just one country. So this is quite interesting. Well, for us, with Professor Tabu, we do think that taking into account portal hypertension is really important even in the setting of advanced HCC. Why? Because we had really bad surprise, as some of you, and for example, we had this patient, which is another one, in who on the first upper endoscopy, we saw just really small varices and we decided not to treat, but we had really a bad surprise because just after the second infusion, she presented hematemesis and a really aggressive variceal bleeding with really large site varices, and this was just after 2 infusions of atezobev. And when we had a look to the CT scan, HCC disease was stable. We did not observe any progression. So we don't know why, but we do think that under immunotherapy and also bevacizumab, maybe there is a risk of increase of portal hypertension in this patient, and we are in favor of proposing beta blockers to hold the patient with varices regardless their size. So this is what we are doing now in France and in my center. And regarding the choice between ligation or beta blockers with Professor Tabu, we are more in favor as Professor Sarin to propose first beta blockers and not ligation. Why? Because also we don't want to delay too much the treatment, as this was already discussed, because we had also bad surprise when we use ligation with bevacizumab with bleeding after on the ulcer. So now we are really careful. And also we have this idea of the BAVNO 7 criteria. You remember that maybe beta blockers could prevent liver decompensation. So we do use a lot also beta blockers in France regarding this setting in order to prevent further liver decompensation under treatment such as ascites, but also for sure variceal bleeding. So this is our strategy currently, but for sure we don't have a lot of data. We don't have a really good trial. We can answer this question, and for the moment I do think that we need really more data to answer this question, because it is a really important point. But for sure we do think we have to take into account portal hypertension in our HCC patient to improve their prognosis. So if we go back to our patients, so for us, finally, we decided to propose beta blockers only, not ligation. So we've got this patient with these large cell varices, red marks, and also active anticoagulation. Will you propose atezobev in such situation, or would you move to other treatment, such as diovatremestide or maybe lenvatinib? What will you do in this setting? Is there anyone we will go on with atezobev, or you think it's a bad idea and you would prefer something else?
How about durvalumab plus tremelimumab? This situation very risky for bevacizumab.
So at that time in France, because we're in 2021, we just had access to atezobev and not stride for the moment, and we had also tyrosine kinase TKI. But what you have to know also is in France, lenvatinib is not reimbursed for advanced HCC. We don't have the reimbursement for this drug, so we are using it, but it's not really well. We do it like that. But this was what we had in mind at this time. So finally, well, for us, we decided to move on, and we propose atezobev in our patients, but considering for sure the potentially higher risk of bleeding in the setting of bevacizumab. But at that time, we started to have more and more data, and also we conducted our own cohort, which I will show you after. And these are just to show you some real life data regarding the risk of bleeding under atezobev. And this was one of the first study published by D'Alessio in 2022. And that included 216 patients with advanced HCC and treated with atezobev in first line. And in his cohort, 19% of patients presented a variceal bleeding, and he did not observe any correlation with the presence or not of portal invasion and the size of variceal varices, as you can see here. And at the same time, we perform also our own study, and we recently published our second paper regarding this, and we included 200 patients with advanced HCC, once again treated with atezobev at first line. Among our patients, 46 presented vascular invasion. 9% of them presented an history of variceal bleeding, and 4% presented an history of variceal bleeding within the last 6 months. So this was, well, not really in adequation with the InBrave trial, but we did it in our center. And as you can see here, half of our patients did not presented varices. And what we observed is that finally we had a variceal bleeding in 20 of our patients. And when we perform analysis in order to identify which risk factor were associated with an higher risk of bleeding, we observed that for sure the presence of varices were associated to this higher risk, but also the presence of portal invasion and also the history of acute variceal bleeding within the 6 months, but it was not significant, as you can see here, for patients with an whole history of acute variceal bleeding, because this also is something that prevented the inclusion in the InBrave 150 trial. And among our patients, we had all of them who had adequate secondary prophylaxis, but only 78% of them had optimal primary prophylaxis. And most of the patients who did not have beta blockers were the one with small varices, because at the beginning we didn't treat it, but after our own experience, we decided to treat all patients with varices regardless the size. And so now what we are doing in our center, so we are lucky because now we can have access to STRIDE. So we propose durvalumab in patients with an history of acute variceal bleeding within the last 6 months, and also in patients with really big vascular invasion VP3. So this is what we are doing, but for sure we can discuss all together. And so if we move on a bit with the case, so finally we decided to do this atezo-bev treatment. We did not observe any side effects, no bleeding, and we just used beta blockers, no ligation. And finally, we were quite happy because after 3 perfusion, you can see that the patient presented partial response. The tumor was now just 4 centimeters. We still have portal invasion, no extrahepatic spread, and liver function was still preserved. And you can see that finally, just after 3 perfusion, our alpha-fetoprotein level was 7. So this was really impressive. This was, well, I think it was our first patient with such a response, so we were really happy. And so my question is, in this situation, will you continue with atezo-bev, or would you propose maybe something else for her? Any local redness therapy?
First of all, congratulations. It's very good for the patients with a dramatic response with the alpha-fetoprotein. It's only 6.8. You have given atezo-bev and with only 3 rounds and with partial response, I will absolutely go for further rounds of atezo-bev if that is the scenario. That's my opinion because he's just responding well with no major side effects apparently, and our concern of the bleedings and he's responding well, and that's what I would be doing with further rounds of atezo-bev.
I think also continue atezo-bev is the best choice, I think.
So what did we do? At that time, we started to think about liver transplantation. And so we wonder if we should continue atezo-bev in the setting of maybe a transplant with the risk of graft rejection. And so we opted for a CERT, radioembolization in this context. So this is what we perform. And finally, we were quite happy because this radioembolization went quite well with still a partial response. The tumor was lower, 23 millimeters, so we were quite happy. And the alpha-fetoprotein was still normal, but we still have some viable disease here. And so we decided to continue after this radioembolization to restart atezo-bev in order really to obtain complete response in order to move on with liver transplantation. So this is what we do. And I will just show you also this study because this is what we are doing also now in my center. And we wanted also to study finally the impact of combining atezo-bev with radioembolization in our patient. And we conducted this retrospective study. I agree that there is really a few patients included for sure, but it was most a proof of concept. And we observed quite interesting results. As you can see, our strategy was to propose atezo-bev 3 infusion before radioembolization, then radioembolization, and after to continue with at least 6 infusion and to continue atezo-bev until complete response. And you can see that finally our results are quite interesting because we observed an higher overall survival and progression-free survival in our patient treated with the combination of treatment. So this is just a small study, but it's like a proof of concept, and now we are continuing with this strategy, and really we have really good results, and we hope to increase our cohort. And what also interesting to see that finally the tolerance of the combination is quite good because we did not observe any side effects related to immunotherapy. And regarding liver decompensation complication, it was quite similar, such as ascites in the two groups. So this is quite interesting. I don't know if you are doing this, combining radioembolization and immunotherapy in your countries. Is this something common or not?
No, not at all.
Okay.
Sometimes it all depends on the availabilities of the strategy. You mentioned about liver transplantation. So actually, I want to know what is the waiting time for such cases in your country? Because
It's really long.
sometimes it's really the problems to get the transplant. So it depends on what we are going to use as a sort of bridging or downsizing for this type of patients. And also for the considerations of the risk of rejections after transplantations with the use of immune checkpoint inhibitors pre-transplant. So there's quite a few discussion points around here.
Yeah, you're absolutely right. Well, in France, it's quite long. It's more than 1 year to get access to liver transplant. So for sure, we have to propose them treatment in between. And for the risk of rejection, I will discuss it a bit later. But now, at the beginning, to transplant this kind of patient with really advanced HCC, we decided to obtain complete response. Not only down staging, we really wanted to have complete response and to have this complete response during at least 6 months to be sure that the disease is not coming back again. And after we started the liver transplant process, and also we decided at that time to stop immunotherapy during at least 6 months before going to liver transplant. But now we are opting for 3 months, and we are not waiting for the complete response. Now we are transplanting patients with downstaging with our alpha-fetoprotein score lower than 2. But for sure, we need to wait at least 1 year with this really advanced patient with stable disease under treatment. Well, this is our strategy now.
Okay.
So yeah. So finally, we started again the atezo-bev perfusion, and 3 infusion after. We were a bit worried because we noted that finally our patients started to present a worsening of her liver function, and we noticed some ascites on imaging, and also we had a child pug B score at that time. And so my next question in your practice with atezo-bev, do you continue atezo-bev in patient with child pug B patient, or do you stop the treatment?
7 is okay, but 8 is maybe stop.
So first of all, I don't know where is the viable cancer tissue. How can you tell this patient is not now partial response or complete response, because the CT scan you showed didn't show the hypervascular area or washout area at all. So how can you tell this patient? Did you have any other imaging studies that which show the viable cancer tissue in this case?
Alors, yeah, sorry, I just put some imaging, and at that time, no, for this point, no, but you still have a bit of variable disease, still some hypervascularization of a small part of the infiltrative lesions. So that's why I can say that it was partial response, but it was still not a complete response. But I'm sorry, I didn't put any imaging there. But usually we do CT scan every 6 months in France, CT scan, and at that time we were doing also MRI, so we combine the 2 examination in order to prevent this answer.
We Japan are not familiar with the radioembolizations, and then do something for the liver to make decompensation things.
Yeah. Unfortunately,
We
yes,
don't,
this can happen. This can happen, and usually it happens after 3 months, and it's like usually you have a worsening of your liver's function with some ascites sometime, an increase in bilirubin, lower albumin. So this is quite common. Well, not quite common, but it can happen, and usually it happens like 3-6 months after the treatment.
Sometimes it takes longer.
Even longer, yeah.
Yes, even longer. That's sometimes it's difficult to control. Sometimes.
So, that case.
Alors, what did we do? So here also is to discuss a bit with you. So in the setting of portal hypertension, what we could do in patient with ascites. So this is also something we are doing in my center. So in this patient with immunotherapy and child pug B patient with ascites or low albumin, we are used to propose albumin perfusion at each infusion of atezo-bev treatment. And why are we doing that? It's according to the result of this study that I think you all know, the study ANSWER, in which they compare the outcome of cirrhotic patient. There is no HCC patient in this, but they compare the outcome of patient treated with some ascites under diuretics, and they compare the outcome between a standard treatment, so diuretics, and diuretics plus albumin every 2 weeks during 18 months. And at the end, what was interesting in this study is that patients treated with albumin presented a significant higher overall survival. Also, they presented lower occurrence of refractory ascites. And so we conducted also this study when we included 57 patients from 2 centers in Paris. So in La Pitié, we are used to propose now atezo-bev and albumin every 3 weeks. And Avicenne, which is another center, they just do atezo-bev in child pug B patient. And here also we have some interesting results. So once again, I agree that the cohort is really low, but it's a proof of concept. We did not observe any difference in terms of survival, but what was interesting in that in our patient, child pug B patient treated with albumin, we had significant lower acid development in our patient. So this also can be discussed all together, but this could be also something good we could propose to our patient with advanced HCC and ascites. Who we want to propose systemic therapy, because also we had really interesting response regarding immunotherapy in child pug B patients. So now we are used to treat child pug B 7 and 8 patients with albumin. And so if we go back to our case, so finally we continue with 6 infusions of atezo-bev. We succeeded to control the ascites with diuretics, and we obtained complete tumoral response after the 6 infusion. And so we move, I will maybe go a bit ahead, but we decided to go for liver transplantation for this patient. And so we register her in August 2020. So 6 months after the end of atezo-bev, and she was liver transplanted, well, more than 1 year ago now, in January 2023. On the explant, we did not observe any tumoral cells. And finally, it went quite well, even if we observed some cholestasis, but we performed a biopsy and there were no sign of rejection. So we move on with the immunosuppressive therapy. And today she's still without any recurrence. Alpha fetoprotein level is normal, and she's really good. So this was my case, and this is just, maybe if you want to discuss this, but the time, there is still this big question regarding liver transplantation in this patient with immunotherapy. When should we go to liver transplantation after we start immunotherapy? And for us, we decided to do it after 3 months. And this is also what we can observe in the recommendation of APASL published this year. So to conclude, I would propose this algorithm. So this is what we are doing in my center, but once again, it can be discussed. And for the moment, we really have few data, so it's a bit difficult to propose something. But what we do is that if you have so advanced patient with advanced HCC that you want to propose systemic therapy, so for us, our main goal to choose a treatment will be portal hypertension. If the patient presents an history of varicose bleeding within the last 6 months, for sure we propose ligation and beta blockers as it's proposed by Bevno. But we prefer now to move through Durvatrem in first line and avoid Atezobev. For patients with an history of acute varicose bleeding higher than 6 months, in which varices are well controlled under beta blockers ligation, we go through Atezobev. And if it's still, well, with a really impressive varices, we prefer to use Durvatrem and TKI. And for the other patients, if you have also a vascular invasion VP4, we prefer to use Durvatrem. But for all the other patients, we go through Atezobev in first line because we are excellent result, and for the moment is also less expensive than Durvatrem. And for the moment in France, we can just prescribe Durvatrem in patients who present contraindication to Atezobev. So this is my last slide, and I thank you a lot for your attention and your discussion.
Very good.
Congratulations.
Thank you.
Wonderful. Yeah.
Amazing.
Amazing.
But it's really interesting to
Wonderful.
discuss about the
Yes.
different habits. It's
Yes.
yeah,
Yes.
really
Something
Good.
with everything.
Thank you.
Wonderful.
Oh,
Thank you so much.
Congratulations. Yes.
Yes, indeed.
Congratulations.
excuse me.
Congratulations.
May I have additional questions? What is the immunosuppressive therapy you are adopting in these cases with a history of Atezo-Beaver and also oil therapy? Would you modify?
yeah.
Will you modify your immunosuppressive therapy in these
Well,
cases?
in France, we are used to just after liver transplant. So usually we use corticosteroid, steroid, mycophenolate mofetil, and we use tacrolimus. And in that case, the objective of the tacrolimus was a bit higher than the other patient. So just after the liver transplantation, during the 2 weeks, we were more than 10, as like objective. But after, we just go back to normal.
Yeah, let me comment. If this is a Japanese case, we may use a lenvatinib, but maybe lenvatinib cannot give this kind of wonderful result. Congratulations.
But
Excuse me. So,
yeah.
from the Japanese point of view, I would like to ask, why do you think this case liver transplantation is necessary? Because in Japan, so liver transplantation is very limited, not widely available. So, why do you think in this case liver transplantation is necessary? Because the patient can get a complete response by the atezolizumab and bevacizumab. Why do you think you need follow the liver transplantation?
Liver function.
Yeah,
Liver
you are
function, but
absolutely
child
right.
B still, child B
Yeah,
not
well,
so bad.
For this patient, we were a bit worried by the portal hypertension presence, the ascites again under treatment, the worsening of the liver function. And also this patient, she has metabolic disease. So we know, well, by experience, because this is typically the French patient we have alcohol metabolic. With time, they present liver decompensation, and she was really in good health. She was quite young, so we wanted to try this and this was liver decompensation, portal hypertension, and metabolic disease. But you're right, because at one point in France we started also to do surgery to this patient with complete response. And what we notice on the pathology is that finally a lot of them, they really present complete response without any tumoral cells. So now we are not really sure that we need to do surgery or to transplant everyone with complete response under immunotherapy, because for some of them, especially after surgery, how patients were in complete response, we performed surgery and after they presented liver decompensation with ascites, and we did not succeed to control ascites. So at the end now we are really wondering if this surgery approach is really a good thing when you have complete response under immunotherapy. But I think we need more time and to analyze, this patient to see if they present recurrence later on. For the moment, we don't know, but now we are more cautious because we are also had bad surprises.
Good.
Okay.
Good.
Yes.
Very
Very
good.
good. Wonderful.
Wonderful. So time is coming. So Professor Manuel Arel, thank you very much, and thank you everyone. I would like to close the grand round. Okay. So now let's move on the second part. In the second part, Professor Stephen Boripo from John Hunter Hospital in Australia will give a lecture titled Management of Portal Hypertension in HCC. Professor Stephen Boripo is a master endoscopist, not to mention the author of many publications. He is also passionate about education. Professor Boripo will continue to impart important knowledge to us today. I'm looking forward to this lecture. So let's get started. Professor Stephen Boripo, please begin your lecture.
Thank you. Thank you for this opportunity to present for the first time to an APASL webinar. What I can reassure you is that this presentation is very short, and it's there's going to be a lot of themes that we already discussed during the previous presentation. So I'm hoping that this talk will summarize all of the various topics that we addressed in the grand rounds. And thank you to Ashok and also to Professor Sarin for inviting me to join. And I come from Newcastle, and this is north of Sydney. We serve a population of 1 million people with our tertiary referral center. And I was amazed with the results of the previous patient that Professor Allais has presented. If the same patient was in Newcastle, I don't know whether she would have received anything beyond the initial part of the immunotherapy, because we don't have approval for using additional treatment on top of immunotherapy. So this patient had immunotherapy, then the radio, and then subsequently had a transplant at the age of 65 with portal invasion, all of those things. So many of those things, I don't think this patient in Newcastle would have benefited from all the amazing things that you've done in Paris. So this really highlights that worldwide there is so much variation in the way we manage HCC and the way we manage portal hypertension, and even within the country in different centers. So hopefully seminars like this will help us share our knowledge and perhaps even out the playground for the benefit of our patients. So a brief outline of the topics that we're going to talk about. So we're talking about HCC, portal hypertension, and introducing the concept of calling cirrhosis as compensated advanced chronic liver disease, as per the Baveno document, because cirrhosis is a histological diagnosis and not everyone is having a biopsy. So I don't know whether you're using this CLD in your documents. So compensated cirrhosis, as in people with liver stiffness anywhere from 10 to 15 or more, and clinically significant portal hypertension as defined with hepatic venous pressure gradient of more than 10 millimeters, or in those people with stiffness scores more than 25 or platelet scores under 150. And so the acronyms that we're using: hepatic venous pressure gradient, portal pressure gradient, and to briefly touch on the changing paradigm in portal hypertension management since Baveno 7. And when I mention elastography or liver stiffness, I'm referring to FibroScan, and AVB is acute variceal bleeding, and portal vein thrombosis there. So I just wanted to show this slide as a tribute to Professor Saran, who is in the audience. Thank you, sir, for your work. When I was trying to read up, I found these two papers, the most useful. And now I know why a lot of my talk would be paralleling the previous presentation. It's because I was quite impressed by the paper from Professor Tabu, which is where our previous presenter comes from. And so I highly recommend these two papers to the audience. So why do we worry about this combination of portal hypertension and HCC? Firstly, because they do coexist more than half of the time. We know that even in early HCC, up to 50% have portal hypertension, and you can imagine that it's going to be much more in the more advanced HCC. When there is combination of portal hypertension and HCC, the prognosis is poorer. And also, just the fact that somebody has clinically significant portal hypertension, that itself increases the occurrence of HCC. And occurrence of HCC itself increases the hepatic venous pressure gradient. And also, sometimes the HCC in combination with the portal vein tumor thrombus or a thrombus itself lead to worsening of portal hypertension. And when there is combination of portal hypertension and HCC, the mortality is a lot higher when there is bleeding. So for all of these reasons, this is an important topic to consider. Of course, portal hypertension is a very simple topic. I mean, there are three things that can happen. You can have ascites, you can have bleeding, you can have encephalopathy. We all know how to manage ascites, diuretics, and salt restriction, and beta blocker therapy, bleeding, band ligations, somatostatin or octreotide infusions. And when things get worse, we have interventional with TIPS or BRTO or other interventional things. And with encephalopathy, we have lactulose and we have rifaximin and the combinations. So portal hypertension is a fairly simple topic with those three things, and that we all know how to manage. One, there is no liver cancer. But when there is liver cancer, things get a bit complicated. So when do we screen for portal hypertension? It is different when there is HCC versus when there is no HCC. Yes, in patients with HCC, this is the one that Professor Ali was previously mentioning, that perhaps there is a role for no endoscopy if the stiffness score is so high that it's more than 25, and you're already going to start them on carvedilol, then you could question, do you really need an endoscopy? And but when the scores are lower, somewhere between the 10 and 20, and they're not already on beta blockers, then there is a role for screening endoscopy to see whether they should be on beta blockers. But all of these kind of things came in during the COVID pandemic. I think now when we discuss the same thing, it sounds a bit silly thinking, wow, we're all endoscopies. If somebody's got HCC, they've got portal hypertension, why not just do a scope? Why take a guess about portal hypertension? Let's just do a scope and see the varices. But I think we forget how bad the situation was during the pandemic, about the access to endoscopy and all our fears about endoscopy. And in that setting, when we're thinking about doing screening endoscopies, we were thinking about all these options of, can we really avoid endoscopy in at least some group of people by using non-invasive criteria. So there is a case for not offering endoscopy to certain patients with HCC. And we talked about this. So So I guess the answer to the question, can we avoid endoscopy? The answer is yes and no. Because we can have a false negative Baveno, and sometimes platelet counts can be higher because of the presence of liver cancer, and sometimes the liver stiffness scores can be higher because of the liver cancer. So I think we can't really totally rely on Baveno criteria in people with HCC. So it's probably best to scope, even if the platelet count is more than 150, and even if their scores are less than 15, if they've got HCC and you're going to go ahead with treatments, especially systemic therapies, it's best to scope and then even scope regularly, maybe another one in 6 months' time, because things can progress. And if there are varices, I think there is still a good case for going with beta blockers in preference to band ligation, because we do need to consider that post-banding bleeding rates are, even in people without HCC, the rates can be as high as 15%. And sometimes these bleeds can be fatal. And it's a shame that if somebody comes to you with HCC and you're doing a screening gastroscopy, you find the varices, you band them, and then 3 days later they died in ICU with a variceal bleed post-banding, and they haven't even had a chance to have their HCC treated. So I think whenever we're doing prophylactic band ligation, whether it is primary prophylaxis or possible secondary prophylaxis, it is reasonable to think that in this day and age, when we have good beta blockers, whether it is reasonable to avoid banding and perhaps use beta blockade, and then not delay the treatment. Now, this was a slide from ASLD, and where we were talking about the changing paradigm that, previously we were talking about beta blockers as prevention of variceal bleeding, but now we're talking about beta blockers to prevent decompensation. So there are even more indications for beta blockers. So I think anybody with HCC should just go on beta blockers unless there's a contraindication. I'm just overstating it, but it is as important as that. Now, regarding tips and management of esophageal varices, previously we used to call them the early tips, or now we're calling them preemptive tips. So placing tips even within the first 72 hours after an acute variceal bleed is sometimes necessary in patients, but sometimes when it is happening in a patient with HCC, there is concern whether is it reasonable to use tips in someone who has HCC? Will it make the liver cancer spread? Will it cause liver failure? But not necessarily. And I think it is worth considering and worth having a conversation. And even the risks, the theoretical risk that, will be risky in someone if they had tips. I think all of these are considerations, but that shouldn't put you off from offering tips in those who would actually benefit from tips, even when they have HCC, especially if that's going to enable reduction of portal hypertension and give them access to local therapies, and even as a bridge to transplant. Now, among systemic therapies and portal hypertension, TKIs can sometimes increase ascites, and in immunotherapy with bevacizumab, the bleeding risk of bevacizumab that we need to consider. And some, if we have done band ligation, we're not going to be eradicating varices with one session of band ligation, but even if we think it is, we still need to wait at least 2 weeks and sometimes up to 4 weeks after banding, depending on the risk of bleeding. But sometimes in the right setting, it may be reasonable to just go ahead and start with immune checkpoint or monotherapy. and if you have access to other drugs, like currently in Australia, we don't have access to anything other than A and B. So we don't have access to Durwa. So we would either go with A and B or A as monotherapy if we're concerned. And while we're on the topic, if the patient has a strong indication for anticoagulation because of portal vein thrombosis or another indication, we shouldn't hesitate to anticoagulate, even if we're going to be treating them with A and B for systemic chemotherapy. And even if they have varices, I think the benefits of anticoagulation is far greater, that we shouldn't hesitate to use anticoagulants in these patients. So in summary, HCC and portal hypertension coexist and they complicate each other and increase mortality and also worsen the prognosis. So it's important to screen for clinically significant portal hypertension in everyone with HCC, which means most people requiring endoscopies, nearly everyone, especially in these days that, we're post-pandemic and we're not so concerned about offering endoscopy to someone. But just because you've done an endoscopy doesn't mean that you should be tempted to band if it's not necessary. And wherever possible to start them on beta blockers to prevent and reduce portal hypertension. If you decide to do banding cautiously, and if they need tips, tips is not out of question in select patients, and it's okay to use anticoagulants. And if you don't have access to the newer combinations of systemic therapies, it's okay to use monotherapy if you're concerned about the bleeding risk of bevacizumab in selected patients. So hopefully that just gives you an overview of things that we already discussed so far. And I hope that we now have plenty of time to discuss and debate, and I'm looking forward to learning from you all. Thank you.
Thank you very much, Professor Bolipo. Professor Bolipo gave a clear explanation of management of portal hypertension in HCC. Do you have any question or comment from audience? Okay.
And I thank Professor Thabu for the excellent article, if you could pass it on.
Any comment? Portal hypertension associated with the hepatocellular carcinoma is a major problem that determines the strategy of liver cancer treatment and prognosis of the patient. Therefore, we now understand how important the management of portal hypertension is. Thank you, everyone. With your help, the 13th session of the APASL liver cancer preceptorship program has been completed. Any final comment from the organizers? No?
Well, one of the best sessions. Congratulations.
And thank you very much.
Very good.
Yes, very good.
Thank you, Professor Mata.
Hi, how are
Professor
you?
B. Thank you.
Thank you very much.
Very
So-
impressive.
so-
Amazing.
Thank you.
Yes.
Thank you very much.
Right.
I would
you so
like
much.
to close today's
See you,
session.
Sarin. Very
Yes.
Thank you, Professor
I
B.
need your comment,
And
last
Professor
comment.
B.
Well, yes, I think it's a very, very emerging area. And I'm very happy, Professor Omata, to spend all the time to join it. And both the talks and the grand round were very good. We see it every day. I just want to add one or two small points. Von Willebrand factor and ADAM-TS are two other non-invasive markers in the blood. And Dr. Omata is carrying a very large AHOC study in the Asian region. If we can decide on natural history of patients with or without portal hypertension and the outcome in patients with liver cancer, I think we can design studies for non-invasive markers and invasive markers, including the blood tests. I think it may be good. But the sessions are very good, enjoyable, and opens new windows. And I'm also very happy our president could join and stay. Thank you, Professor Obi, and thank you, Masao, for this opportunity.
All right. Thank you.
Thank you, Shinji-san.
Thank you.
Thank you,
Thank
Professor
you,
Rin.
everyone.
Thank you all.
Thank you, everyone. Thank you for the opportunity.
Good night.
Now I would like to close today's session. Bye bye.
Bye bye.
Thank you very
Bye-bye.
much.
Thank you so much, everyone.